I'm Jeremy Faust, editor-in-chief of MedPage Today and the author of the Inside Medicine newsletter on bulletin.com. I'm joined today by Dr. Deborah Birx. And Dr. Birx, thank you for joining us. Dr.
Happy
Birx,
to be here.
Thank you. Dr. Birx was, well, before she became a household name, Dr. Birx ran the CDC's Division of Global HIV and AIDS, and she oversaw PEPFAR, which is the President's Emergency Plan for AIDS Relief. PEPFAR, which is one of the most successful public health interventions that our government has been a part of in recent decades, I would say. And then, of course, everything changed in 2020 when she became the first White House coronavirus response task force coordinator. Her new book, Silent Invasion, is a detailed account of what it was like on the inside. And it is fascinating. I just finished reading it. It is bold. It is you pull no punches. Thank you for writing it, and thank you for being here.
Thank you. I mean, I've written a lot of scientific articles and a lot of chapters, but that was my first attempt to translate science into a book format.
So let's talk about this book, Silent Invasion, and I think I'm the intended recipient of this book in the sense of who I vaguely thought you were and who you are. Tell us about that gulf. What do people think of you, and what do I successfully know now that I've read it?
Well, you know, if you asked anyone around the globe in HIV, they would tell you who I am. Hard driving, data driven, will do anything to ensure people's lives are saved. And I knew when I was working on HIV that my patient was never the Ministry of Health. My patient was the community at risk for disease. And so that's how I went into the White House. I mean, the White House, yes, it was where I was working, but my loyalty was to the communities and the Americans that were at risk for COVID.
But you strike me in the book as just a complete data wonk.
Yes, total data wonk.
Yeah, and that's pretty much why you were brought in, is that right?
I think so. I think two things. One, I had actually battled a pandemic and successfully. I mean, we have really made incredible strides on HIV and HIV-TB in sub-Saharan Africa and around the globe. But secondly, we did that through data, making everybody visible that needed our help, not just the people we could see, but the people we couldn't see. And that's what data allows you to do. But data is irrelevant if all of it does is it creates an article. Data has to lead to action. And data has to be transparent. And so anytime we would change policy or guidelines or ask for ministries of health to change policy or guidelines, we all agreed on the data and the reason that we needed that policy change. And I think in this country, we need to make data accessible to every American so they can analyze it themselves.
Yeah, I mean, this is what I write about in my newsletter, and it's sort of my little shtick too. I was like, oh, okay, she was me in the White House, and that's what it kind of felt like. And in fact, there's this moment in the book where you talk about that you're on Google using Google Translate to read the Diamond Princess statistics, and I did the exact same thing. And I wonder if like we could find out, you know how you can see page views, like how many people translated the Diamond Princess pages from Japanese to English? Like, well, at least 2.
Yes.
But, and tell me about those moments and when you started to realize the extent of asymptomatic transmission of this disease.
So I felt like it had to be happening in January because you don't build a 1,000-bed hospital in a matter of days or a 10,000-bed hospital if you don't have unbelievable community spread. Because we don't have any viral diseases that only cause severe illness in one tiny group. Other people have to be becoming infected and not seen. So, but I couldn't prove it. And I think the Diamond Princess, for those like yourself, who really took the time to really look what happened in the Diamond Princess, you knew it had to be the crew.
Right.
You know?
Well, and also
so to me, it was very clear, but not to everybody.
And also the transmission dynamics
Yes,
are so bizarre.
exactly.
Because you have a spouse living in a cabin, not getting it from their spouse, and yet at the same time, as you mentioned, in MMWR, the CDC's journal, Morbidity, Mortality, weekly report, we see this thing where one person in a choir gave it to dozens of people. And so it's a very strange pathogen, right? It exploits our assumptions that we will not, we're going to hunker down when we get sick. And this virus says, no, I'm going to spread right before that happens.
Yeah, and I'm going to spread with young people who don't know they're infected. Yeah. And no one, I just want to always make this clear. As with HIV or any infectious disease, people are not intentionally spreading it.
Right.
they truly don't know. And it's our job, as those of us in medicine and science and technology and healthcare, to make sure that they have the tools to utilize that successfully to protect themselves and their family.
So when you talk about the kind of realizing the extent of asymptomatic transmission.
I love that you were doing the Diamond Princess translation too. I just love that.
Yeah, I mean, it was very frustrating because they wouldn't update it often enough. And I took home 2 messages. One was, this is a very contagious pathogen.
Yes.
2 is, this is very, very dangerous for my parents' generation.
Yes.
And I thought, well, it may be fine for everyone else. Took until later data sets to realize that we'd have excess mortality in young people, which we just didn't have a big enough N at that point. But yes, but you talk about in the book, I love this, you said somewhere between 3 and 10 times. You know, if given the tip of the iceberg at the beginning of an outbreak, if there's 100 cases, there's probably 300, there's probably 1,000. So this is the first time we ever heard about an R naught for this virus. That's the reproductive number. This is the number of people, the average person who gets infected subsequently infects. That's called an R. And this first number we were given was 2.58, which was a very alarming number. And then it was upgraded. But actually, when you take into account asymptomatic transmission, it's far higher. And I was part of a team that actually thought it was much higher. What do you think the R was? Then I'll tell you what we thought it was.
I thought it was between 4 and 5. And when I tried to paint that picture in the book, because I had this group of people that I'm so grateful for that came and worked with me, because I didn't know what was going to happen to their careers. And I was older in my career. So even though I knew it was going to be terminal for my career, I didn't want that to happen to other people. But they understood how much I valued data, and they understood I would need a team. And so 3 or 4 people showed up. And we argued about that and the degree of asymptomatic spread, because those two are so critically linked. So I thought asymptomatic spread was well into the 50-60% range by age group, could vary up to 85%, and we were able to get that data from colleges when they started testing regularly. But that's what was driving the double and tripling of the R naught for me.
So I'll tell you a funny story. So I was the middle author on a paper that we thought it was more like in the teens. And this was sent to a journal, and they sent it back, and they said, well, that's impossible because it would have to be an airborne virus.
Yes, it is an airborne.
And
yes.
that was the end of that. So.
Yes. And that's, what's upsetting to me is you and I, looking at the Diamond Princess data, are like, this is an aerosol, this is highly contagious, this is being spread asymptomatically, this is going to be a huge problem. And other people are saying it's on the surface, it's droplets, not realizing that that is just incomplete partial RNA fragments that results in everybody wiping down their groceries rather than understanding aerosolized spread, which means it stays in the air for a number of hours. And I always say to people, it doesn't matter who's in that room when you get there. It matters who's in that room before.
Turnover, right. No, and this is the thing, like, I'm not a domain expert on aerosols, but recognizing that, my answer was, there were a lot of people who were very territorial. Oh, it's not airborne. And I said, well, look, I don't know. All I know is it's airborne enough.
The data said it was airborne.
Well, it was just, it was moving through the air. And I didn't want to get into like whether it was extended droplets or this or that. But talking about asymptomatic transmission, and you do talk about testing. And we all know the documentation of how we didn't do testing right. But you also, we have a lot of agreement on the use of rapid tests, rapid antigen tests, and the idea that these are tests that might miss an early infection. They certainly will miss a late infection, but they should get you right when you're contagious, which is really the way you stop things. When did you first understand that?
Very early. So when we had that first meeting, March the 4th, with the companies, and these were companies I knew from HIV, and I knew their capacity to produce tests, and we asked for PCR tests, antigen tests, and antibody tests, because I knew we had to get into the community, and it had to be simple and fast, because we needed the 20 and 30 and 40 somethings being willing to test, and they were not going to go sit in a drive-through for 4 hours and wait 5 days to get an answer. It just wasn't going to happen. But people would self or come by quickly, do an antigen test, and they would have come back daily if we had asked them to. People were very responsive and really responsible. I never saw in all of my trips people being intentionally irresponsible.
Right. The rapid kind of story is a little bit murky, but it seems like the FDA didn't really approve or authorize many. Is that fair to say?
So here's the circular reasoning, and you would understand this completely. So all of the original tests were done on a set of specimens that were collected from people who were symptomatic, because we didn't have enough tests to test for people without symptoms. And so they wouldn't approve it for asymptomatic use, and that was its value. And so because they wouldn't approve it for asymptomatic use, then even though I showed them the viral load in the nasal cavities were identical between the asymptomatic and the symptomatic, they wouldn't approve it for that. And that resulted then in the CDC sending out guidance that it was provisional. Well, no one's going to test twice. And we didn't have the resources to have everybody who was antigen positive go back and get another PCR. And so it really hampered us. And they didn't approve antigen tests for asymptomatic testing until the summer of 2021.
Do you think these tests are still misunderstood? A lot of my colleagues, really smart people, say that it gives people a sense of false security, and therefore they go and they infect people.
Absolutely not. If you explain it correctly and you say to them, these tests are for that moment in time. And so in that moment in time, you may be negative. Tomorrow you may be positive. And so if you're seeing your grandmother 3 days in a row, you're going to have to test 3 days in a row. Yeah. I think we've gone through 500 or 600 antigen tests. I mean, we definitively use testing. Even my daughter's children's preschool tests weekly. I'm so proud of them because it makes a huge difference. Yeah. The colleges that tested weekly had less than 1% to 2% community spread. The colleges that tested only those with symptoms infected 20 to 30% of their population. It's very clear. You have to find the pre-symptomatics and the asymptomatics.
Yeah, I think that's a huge thing that people don't understand, is that it's actionable information. I had a friend call me a few months ago when Omicron, there was a concern, maybe they don't work for Omicron. And they said, we had a family reunion, and this is a really smart person, and everyone tested before they came, and a couple days later, everyone got sick. And I just said, well, wait a sec, let's look at the number of cases there are. The expiration date, in other words, it was good on Wednesday, but by the time you had your little thing on Friday, that was old news.
Yeah, so whenever I walk into an occasion, which I'm sure is a downer, whether it's a wedding or otherwise, I say, there's at least 2 or 3 people infected in here. So let's all be respectful and take care. And unless you tested the second before you walked in the car, I can't tell that you're negative, and that's why I'm masking.
Yeah, I asked the audience here today in my session, what would you rather do, be in a room full of boosted people in the past several months, but no test, or full of anti-vaxxers, but who all had a rapid antigen test that was negative, a few hours ago? And they looked very puzzled. And I've asked this question many times to many people.
That's a great question.
But it's not close. You want to be with the people who have negative tests, regardless of their status.
Exactly.
Yeah, but our minds just don't work that
way.
Well,
I think it's because, and I hold us responsible as public health practitioners and people who have reported on this, and I really appreciate your reporting, because you've really tried to really make it very clear about what we know and what we don't know. When we make broad statements, when we say to people these vaccines are going to protect against infection, one, it wasn't studied. 2, we already knew reinfections were rampant with natural immunity. And so the vaccines that were designed to mimic natural immunity are going to have reinfections. And I think we just don't imply that masks only work one direction. I mean, it's this, and Americans have amazing common sense. And so when they hear that, they stop trusting the message. And I think we are just as guilty for creating that sense of they don't trust us. We've waffled on tests, and we haven't made it clear. We've waffled on masking. We've not been clear on vaccines. And then we wonder why people are confused.
Yeah, no, I agree. And I think we should be humble about what we know at all times.
Yes.
Which is not really our best. We're not so great at that. Yeah.
Well, I think if you had lived through the AIDS pandemic, you would be very good at it. Because, when you've lived through that humbling, I don't know and I can't fix it, that makes you very clear on, this is what I know, this is what I don't know.
Yeah,
and then
it's funny how your lived experience matters. Another part of your book that actually really struck home for me was where you talked about how the experience at Elmhurst Hospital in Queens really probably saved millions of lives. I trained there as an emergency resident at Mount Sinai and Elmhurst. So for me, when I started hearing stories from my colleagues at Elmhurst and hearing the sounds of their voices, I knew that this was real in a way that I hadn't really understood. And so, and as you say in the book, this landed for Trump, didn't it?
Totally. Totally. I don't think I would have been able to convince him to that 30 days and the reopening criteria if he hadn't had the Elmhurst experience, combined with his friend being hospitalized and then succumbing to COVID. And I think that was so real and personal. And somehow we have to figure out as practitioners, how do we make it real and personal without people having to have that kind of level of intimate experience? And I think that's what we can learn from media training, and that's what we could learn from big marketers, because we have to figure out how to make our messages real for everyone.
I mean, that's like the Ryan White approach with HIV, right? Or Tom Hanks doing Philadelphia. I mean,
Yes.
that's really what that's about?
Exactly. And I think showing people that that is the experience, you don't have to live it.
Yeah. No, and Megan Randy and I wrote a piece about this in, I don't know, April or May, and we said, look, by the time that everyone statistically knows one person who's died of this virus, it'll be 1 million deaths.
Yeah.
And we don't want to wait for that.
We don't, and we did.
Yeah.